and welcome. My name is Robert Pleticha, and I'm a project manager with Admedicum. We've been supporting the Alliance for PH for the last 3 years now as the secretariat, and we're very happy to be helping with these webinars and also the Pep Talks series. So today we have 5 excellent speakers to give you the latest updates on pulmonary hypertension from the last quarter. Each speaker will have 15 minutes to talk, and then there'll be 5 minutes afterwards for live Q&A that I'll help to manage at the end of each talk. If you have any questions, you can ask them then at the end of the talk or put them in the chat at any point. We're delighted to offer that translation feature and have captions in several languages. I'll just put the link again to the Wordly platform if you'd like to switch that on. And this is the third Q3 webinar. So 3 out of 4 that we're doing this year. We're planning one more in the last quarter. And we have a great panel of speakers who are going to be reporting on the most significant developments in the field of PH. And just remember that all webinar materials, including slides and recordings, will be uploaded on the PH knowledge sharing platform shortly after the event. Our first speaker is Professor Luke Howard, who's going to talk about the development of inhaled therapies for PAH. So thank you very much, Professor Howard, and over to you.
Thank you. Let me just get my screen ready. So this should be showing now, and if it's not, let me know. So when I was given this title, let me just turn my phone off so that it doesn't disturb us throughout the next 20 minutes. When I was given this title, The Development of Inhaled Therapies, I thought that this was kind of a bit of a look back and a look forward in terms of what I would present. And this is not meant to be entirely comprehensive of all the development. It's meant to give you a flavor for what's on the horizon, really. But it does help when you look back at what has been the progress really since the early 90s in this field. And suddenly you can see that there is this explosion, this really exciting explosion of new therapies that is coming through to the stage where, we're almost saturated in the clinic with research trials, and we've got more trials than patients. So this is a very exciting time. I do have some disclosures, some of which do actually relate to inhaled drug therapy companies. So I guess that's good and bad. It does mean I've been involved in some of the development side of things and hopefully know a little bit of what I'm talking about. Now, what have I got up here? So the first thing I'm going to go to is actually an angiogram. So this is showing the blood vessels, not the airways. I'll come on to the airways soon. And this is a very old slide, and it shows the difference in the blood vessels in the lung between a normal subject on the left and a patient on the right with idiopathic pulmonary arterial hypertension. I'm not sure that the 6 months is necessarily relevant. That could be 6 months since diagnosis, but we know that it builds over time. What you can see is this pruning of the vessels. It's almost like a tree which has fewer twigs and therefore fewer leaves on it. And the historic way that we've treated this is by getting drug into the bloodstream so that it can then pass into the vessels and help these vessels to dilate and to widen. And you would also want potentially some more branches to grow. So the historic approach has been to get blood into to get drug into the bloodstream. And the way this is done, this is a very simple circuit diagram with the heart here, which pumps oxygenated blood around the body. So these are all the organs that your heart pumps blood to. One of them, of course, being the stomach. So we would ingest drug into the stomach, and it would get pumped, and it would get pumped back to the heart, and then enter into the lung and enter into all of the blood vessels of the lung. So that will be the historic way of doing it, or for example, an intravenous infusion such as prostacyclin, which goes directly into the vein and then into the lung. So that seems to work pretty well. We know that. So why would we develop inhaled therapies? Well, there are 5 reasons, and I'm going to go through these throughout the next 10 minutes or so. So one would be to get drug into the lung, which is where the disease is, where it's most likely to give you the most benefit, and not give you harm. So, for example, there might be side effects if that particular medicine can get to other parts of the body. Alternatively, it could be to get therapy into the body that can't be easily taken by mouth. So, for example, if you were to take sort of prostacyclin-based therapies, so like treprostinil, for example, or Orenitram, that directly can be difficult in terms of some side effects. So one way is to get it straight into the lung where it may not cause those side effects. If you've got a very short-acting drug, so a drug that, for example, only lasts for about 5 seconds, then clearly it's got to get straight to the place where it's going to do its job. So that would be with a continuous gas. And then the other, number 4, is to get a therapy closer to the site of the disease where there will be minimal spillover to the rest of the body. And then finally, you might want a drug that you can just take a quick puff of prior to doing any exercise, for example. So you want something that gets there quickly, doesn't take time to absorb, and then works in order for you to then get on and do the activity of interest. So if we look at the anatomy, it makes sense. Here's the sort of the big overview on the left, and then you can see on the in the middle, you've got the trachea, which is the main windpipe. If you inhale drug, it will get down into the tubes, the bronchial tubes and the bronchioles. So for patients with asthma, for example, this is clearly the most sensible way of inhaling drug because it needs to work on these bronchial tubes. Now, to work on the pulmonary circulation, the particle size is going to need to be a lot smaller. So these drugs need to be specially engineered so that it can get right down into the very small airways. And here we've got a blow up of these airways that as they go right down and they get towards the alveolar air sacs, where you get exchange of oxygen and carbon dioxide. But you can see just here, I hope my cursor is showing, just how intimately related these air sacs are to this blue vessel, which is the pulmonary artery, carrying blood into the lungs, where the site of the main disease is in pulmonary hypertension. And so here, if we can get drug down to here, it can diffuse across into the vessel and act right at the site of the problem. So I'm going to talk a little bit of history now, and I'm going to talk about how we can deposit drug in the area where it's most likely to do benefit and not cause harm, and also where it can be difficult to administer by mouth. So back in the early 90s, and thanks to Werner Seeger for providing some of this history for me, they were looking at patients with a syndrome called ARDS, acute adult respiratory distress syndrome. So this is something that typically happens in patients on the intensive care unit. And you can see in this patient who's been scanned, who's lying on their back, that the normal lung here in black is at the front of the chest. And where they've been lying on their back, the back of the lung is filled with effectively with fluid. Now, if you were to give a drug by intravenous infusion or into the stomach, it will go into the blood circulation and be distributed to the whole of the lung. So you'd have drug going to this area and this area. Now, clearly, there's no air getting into this bottom area. So if you open up the blood vessels in this bottom area, then you're going to get more blood going through bad lung. And so that means it's not going to be picking up oxygen, which is obviously clearly not what you want. And on the right-hand side, and I'll just draw your attention to these two bottom graphs here. The 3 patients are given drug at time 0. And what we can see is this increase in the amount of oxygen in the blood in relation to how much they're breathing in. So there's an improvement in this ratio, which then wears off after 60 minutes. And this is prostacyclin, which is the drug that many patients are given by intravenous infusion, but this was given in an aerosol. And what we can see here is a drop in something called shunt. Shunt is the proportion of blood passing through the lung that doesn't mix with air. So there's a decrease. So if you administer it via the airways, it goes to the healthy lung and diverts blood to the healthy lung. And you can see the difference here between an infusion of prostacyclin and an inhalation of prostacyclin. So there's a very nice big drop in the resistance to flow in the lungs, which is the same almost as the pressure in the lungs. However, when you give it by infusion, there's an increase in shunt, so an increase in blood going through the bad bit of the lung. When you give the same drug, prostacyclin, by aerosol, you get a nice drop in the resistance in the lung and a drop in the shunt. So this was really the first exploitation of prostacyclin in this way. But the problem with this drug, as you all know, or many of you will know, is it's got a short half-life of 2 to 3 minutes. In other words, as soon as you stop administering it, within about 10 minutes, it's all gone from the system. So that doesn't make it at all practical. So that then led the group in Gießen to explore this sort of made-up design to administer inhaled iloprost, which has got a longer half-life of 20 minutes. So this is in the bloodstream for longer, and this was the first patient ever to receive this. You can see here that her pulmonary pressures dropped very nicely, and her oxygen levels increased very nicely. And this was the first ever inhalation of iloprost ever given in humans, an improvement in cardiac output. So a very impressive effect. And over a period of a year, this effect was maintained. But of course, you have to keep sustainingly taking it at least 6 times a day because of the short acting nature of the drug. So what we see on the left is something that many of you will be familiar with. This was the initial INEB device for administering iloprost, and now it's the Brelib device. So this is anything between 6 and 9 times a day recommended. Treprostinil is a longer acting form of prostacyclin. So this has a longer half-life, so you can take it every 4 times a day rather than 6 to 9 times a day. So it does have benefits from that perspective. It's not licensed here not available here in the UK, sadly, but many people around the world will be taking this. So that's an aerosol, but also treprostinil has been developed in dry powder and approved by the FDA as Tyvaso, Yutrepia, and then this is also 4 times a day. And then this drug that's currently in trials, about to go into phase 3, which is a once-a-day inhalation of treprostinil with some very nice-looking results. So that's on the horizon and very exciting. I did mention this before in my introduction about how you might get a very short-acting therapy to the site of action before it degrades. And so what I'm talking about is nitric oxide, which is an inhaled gas which, when it gets into the bloodstream, disappears within a matter of seconds. So clearly, you've got a very short opportunity to get it to be inhaled in the airways, to get to the site of action, and then to work immediately. It's obviously great because, of course, it's inactivated in the blood, so it doesn't have any effects on the rest of the body. And it can open up the blood vessels in the lungs, decrease the pressure, improve the oxygen content. However, this is the machine that we normally use to give nitric oxide to people on the intensive care unit or in the cath lab, that clearly you cannot be walking around attached to this machine. There have been 2 other devices that I'm aware of that have been developed. One carries a small canister of nitric oxide with it, and this went through some trials, didn't, as far as I'm aware, make it through, but mainly because a lot of it was happening in COVID, and they used a particular metric to measure the efficacy of the drug. So it kind of hit the buffers, unfortunately. This is another device. I think this is the device that has been developed, and I've not seen how far it's progressed, but this is ingenious. It recognizes that there's nitrogen and oxygen in the atmosphere, and if with a small electrical current, you can combine those two to form nitric oxide, so you don't even need a canister. I'm not sure where that is in clinical development. I was aware of quite a lot of work before COVID, but I've not heard any more since. So that there may be more on that in the future. Now, what about getting a drug to the lungs with minimal spillover? So this might be a drug, for example, that has significant side effects if it gets into the body. So here's an example. This is a drug called imatinib, which was developed for leukemia and was then found to work quite nicely in pulmonary hypertension. It's not a vasodilator drug, so it doesn't dilate the vessels. What it does is it targets the thickness of the vessel wall. So it's something that doesn't give you an immediate relief, but it works over a period of time. And this was actually very successful as a tablet medication over a 24-week trial published over 10 years ago. And this is the 6-minute walk data showing the 6-minute walk in the imatinib group improving by 50 meters and the placebo group by under 20. So there was a 30-meter difference, which is quite big on top of patients receiving 2 or 3 therapies. The problem was that it created side effects. And so one thought, therefore, is rather than giving it by mouth where the drug gets to all of these areas, it could be inhaled and get just to the lung so that it could diffuse from the airways into the blood vessels directly. And this is a trial that reported last year. And what they show in this graph is this is the concentration of imatinib in the bloodstream if you were to take a 400 milligram tablet and over 7 days. So you take the tablet, the dose in the bloodstream goes up and then falls down. And with the inhaled dose, you see a much lower concentration in the blood. So in other words, it's sticking in the lung, but not going to the rest of the body where it might cause side effects. Now, unfortunately, it didn't work. It didn't improve the endpoints in the phase 2 clinical trial, and that reported last year. And I think there's still a fair amount of head scratching going on about why that may not have happened. A drug that has been developed that's related to imatinib called seralutinib, which seems to work at much lower concentrations than imatinib, has been developed and was successful and published last year at phase 2. So that's the early phase. And is just completed recruitment into the phase 3 trial, phase 3 being the trial that needs to be done to get approval by the FDA or the EMA. And what this showed is vastly lower levels of this drug in the bloodstream. So this is something called a logarithmic scale. So what this is showing is that actually you've got 30 times as amount of the drug that's held in the lung if you do an experiment in a rat than in the bloodstream. So it may not look like much on here, but what you've got here is 10 nanograms per mil, and here you've got several hundred because it's a logarithmic scale. So actually the difference between here and here is massive, and it's above the level required to inhibit this important receptor PDGF in vitro, so in a lab. So this was reported this last year, and rather than go through all the data, I thought I'd show you a nice pretty picture. So this is a placebo patient on the left from baseline to week 24 in terms of the blood volume in the blood vessels. And you can see a patient who received seralutinib on top of 3 background therapies, so heavily treated. And you can see how there's more blood vessels opening up, which you can relate back to the angiogram I showed you at the beginning. Now, I'm coming to the end now, and I think one of the important new developments in the last few years is this increasing trend to bring these inhaled therapies into people with scarring conditions in the lung. So with the idea that if you've got other forms of disease in the lung, if you inhale a therapy, it's going to go to the remaining good areas of the lung. So here's a healthy lung on the left and somebody with scarring on the right. And you can see patches of good lung in here and patches of bad lung. So you want the drug to go to the best bit of lung to work. And there's a drug called mosliciguat, which is a bit like riociguat that some of you might have heard of, Adempas, but in inhaled form. And so this is shown not in that particular patient group in early studies, but done in people with PAH and thromboembolic pulmonary hypertension. Very nice sustained drops in pulmonary pressure after a single dose over several hours. So that's now in trials in patients with interstitial lung disease, PH. And then finally, an interesting one, as I mentioned just at the beginning, is the possibility of using a fast-acting drug to use as required. So in other words, it's a bit like people who might take a puff of their salbutamol or their Ventolin, or albuterol, if you call it in the US, prior to doing exercise. So this is vardenafil. So you'll note it's a similar name to tadalafil or sildenafil. So it's basically like Revatio, as it's called, and then I've immediately forgotten the name, the tadalafil trade name, but anyway, you'll probably know it if you're on it. But basically, rather than a tablet form, there's an inhaled form that you take, and now this was the trial design. So they took people and they did a 6-minute walk test and then a cardiopulmonary exercise test on a treadmill. And then 8 days later, they gave them a single dose, just one dose of this, and then they remeasured their performance on the treadmill and on the 6-minute walk test. And the results, I saw them presented at the American Thoracic Society earlier this year, and they were quite impressive. So that's the concept of taking something just before you need it. Right, I'll finish there. And if there are any questions, I will be happy to take them and answer them if I can.
Thank you very much, Professor Howard. Yeah, we had one question from Luis from the Dutch PH Patient Association, who says, I've had some conversations with HCPs who doubt about whether the inhaled medication will actually reach the place where it's needed for PH. Actually, if enough of the dose reaches the right place. Is there enough scientific evidence to prove them wrong?
Yeah, thanks, Louise, for that question. I think it's a very tough one to know, and in a sense, you only know really when you've done the full trial and you can see the results. And I think what's called that into question and why you ask a question is, why did the Aerovate trial fail? There were good doses of inhaled imatinib, and they weren't even micro doses, yet it didn't work. Was it because the drug didn't get to the right place? And it was hanging around in the right place. So with drugs, for example, like iloprost or treprostinil, my view is that in many ways, part of the effect is simply that you're able to get it into the bloodstream and then it circulates around the bloodstream and comes back to the lung. So some of that effect might work that way, but if you're not getting any systemic absorption, any absorption into the bloodstream, and it's simply hanging out in the big airways, then maybe it won't work. So there are quite a few people who are still skeptical. I think the way to make sure that we develop drugs that work is that the particle size has to be small enough, and we have to demonstrate on imaging technology, for example, with labeled drug, that the drug can penetrate deep enough into the lung. And you can also label things and do animal experiments and see where the drug ends up before we then take it through into human development. But I think there is a body of evidence building slowly to say, yes, this may be effective, but I also think we shouldn't throw the baby out with the bathwater and stop focusing on other methods of delivery, good old-fashioned tablets. Patients like taking tablets rather than having to maybe inhale a drug several times a day or inject or have an infusion. That's where we still need to keep a major focus.
Thanks very much, Professor Howard. We appreciate your presentation today. It was excellent. With that, I want to invite our next speaker up. That's Professor Clemens Aigner, who is Professor of Thoracic Surgery and head of the Department of Thoracic Surgery at the Medical University of Vienna. Professor Aigner, take it away.
Yeah, thanks a lot for the invitation, and we'll present you today some important aspects of lung transplantation in PAH. As you just heard in the previous talk, there are tremendous improvements in the medication for pulmonary hypertension. However, lung transplantation still is an important option and should be considered not too late, as I will show you. So I want to give you a brief overview on the current status of lung transplantation with a particular focus on PAH. And then I specifically want to go into detail on referral and listing, and also on the options of bridging with extracorporeal devices for PAH patients. And in the second part, talk more about the surgical details and type of procedure and what specific peri and postoperative challenges we face in patients with pulmonary arterial hypertension and what outcomes we are able to achieve. So the first lung transplantation, as you might know, took place already in 1963, and since then a continuous increase in numbers has been observed worldwide. However, patients with pulmonary arterial hypertension only account for a small fraction of these patients. Here in the data of the ISHLD registry, basically they are summarized in the other group. And if you look more into detail, it's a fraction of about 2 to 3% of patients who actually undergo lung transplantation with this diagnosis. This means that the evidence is mostly limited to single-center retrospective analysis, and larger prospective multicentric series are not really prevalent. In the pediatric population, pulmonary hypertension accounts for a larger fraction of the patients. Here in the yellow, the IPAH, and in red, the other patients with PH. So when we look at our own center's numbers in Vienna, we do about 100 to 120 transplant procedures a year on a constant basis throughout the last years. And if you look at the different indications, you see here in dark blue the patients with pulmonary hypertension, and this also accounts for a fraction varying from year to year, but around 4 to 5% of patients. So when is the ideal time of referral and listing for lung transplantation? The important thing is, as you all know, the status can deteriorate very quickly in PAH. And the important aspect is to build a safety net in case this acute deterioration occurs, and ideally have an idea about suitability of transplantation and the evaluation, if necessary, before this deterioration occurs. When you look at the guidelines of the European Society of Cardiology and the European Respiratory Society, in the different types of pulmonary hypertension, you see lung transplantation is a therapeutic strategy in PAH, meaning type 1. And if you look more in detail, for example, what has been discussed recently in the World Symposium on Pulmonary Hypertension, when the initial risk assessment takes place, this is based on several factors such as functional class, 6-minute walk distance, natriuretic peptides, hemodynamics, RV imaging, and other measures. These measurements put the patient in a certain risk category. And the transplant referral should be considered early on for selected high-risk patients already at the stage of diagnosis, and for intermediate high and high-risk patients at the first or subsequent follow-up. As we all know, the urgency and the risk category can change throughout time, and even patients who are not in the high-risk category at the beginning can deteriorate and get into this high-risk category. Why is it important? Because we know that the urgency of lung transplantation is a clear predictor for the postoperative outcome. And patients with fulfilling high-risk criteria, whether it is according to ESC, ERS criteria, according to the REVEAL or compare methods, all these patients have a worse outcome if high-risk category criteria are fulfilled. When we look at what's actually happening in referral of patients, there's a very recent analysis from North America published in June this year in the Journal of Heart and Lung Transplantation, which shows the reality of referral in PAH patients of the Pulmonary Hypertension Association Registry. And you can see that actually in about 1,670 patients analyzed, only 200 of them were actually referred for transplantation. There are several factors which indicate whether a patient is more likely to be referred or not, particularly the diagnosis of PVOD being an important issue. But the overall summary is that the rates of referral for lung transplantation in patients with PAH remain unacceptably low and occur too late. And an increased awareness of the benefit of early referral is necessary, even at expert centers. So why is it important? Of course, we do not wait until the patient is decompensated and has a poor muscular status and a lot of side problems occur, because then the risk for the transplantation and the perioperative recovery is, of course, much more difficult compared to if the patient is in a better shape. And these late referrals lead to an increased perioperative morbidity and mortality, and ultimately makes it difficult to achieve the outcome we want to have for our patients. So, of course, we do have options available in case an acute deterioration occurs to bridge to the transplant procedure with the use of extracorporeal devices. However, we want to try to avoid these situations as much as possible. So what are the basic principles? Usually the deterioration occurs because of an impairment in the right ventricular function and in the hemodynamic situation. So thus the idea of bridging with ECLS, meaning extracorporeal life support, is to provide hemodynamic stability, to relieve the right heart, and to protect the kidney and the liver function. There are several technical options available. The right ventricular bypass is not sufficient because we need to bypass the pulmonary circulation in order to relieve the heart and improve the hemodynamic situation. So the standard option is the implantation of a veno-arterial ECMO, which can be inserted in the ICU, even in local anesthesia. However, has some issues, and there are different cannulation strategies available, like in the subclavian artery, central cannulation, or a centrally implanted Nova lung, which all have their distinct advantages and disadvantages, and all have the idea to bridge the patient in a condition as stable as possible towards the transplant procedure. A lot of these ECMO devices nowadays can even be used in a setting where the patient is able to ambulate in the status of an awake ECMO, meaning that even some degree of physiotherapy or mobility on the ICU, or as shown in the example here, even temporary transfer and on the hospital premises outside the ICU is feasible in some patients. All these bridging options, however, particularly in the setting of PAH, where a hemodynamic support is necessary, are only suitable for a limited time frame. So, and the actual access to transplantation, of course, heavily depends on the setting you are based and the system of organ allocation. In Europe, there are several different systems of organ allocation in place, some countries with informed consent, some countries with presumed consent, and in some countries, the relatives have a right to object as well. Usually in countries with a presumed consent, the organ donation rates are somewhat higher. However, even within these countries, there's really a huge difference in the actual number of lung transplants performed per million people, and there's quite a variety. And in Austria, we're here in a very good situation, being able to perform a decent amount of lung transplants per million people. With regard to organ donation and how organs are actually procured and preserved, there really have been major advances in the last years. I can't go into the details of all of them for time reasons, but really the advent of 10-degree storage and ex vivo lung perfusion have opened up a broad opportunity of utilizing donor organs that would not have been used before, and allowing a more elective timing of the lung transplant procedure itself. So basically, the main summary in terms of referral and listing is don't wait too long. We have detailed referral and listing criteria. However, whenever there is a doubt, early contact and referral for evaluation of the patient is really an important issue in order to avoid situations where we have to get into bridging of patients, which, however, of course, if the situation occurs, is technically feasible, and a lot of advancement has been achieved in this field. So when it comes to transplantation, what's the ideal procedure performed for patients with PAH? There are several options available. Initially, combined heart and lung transplantation has been performed. However, it has been shown pretty early on that the right ventricle, which here on the left side is hypertrophic, enlarged, and with an only small left ventricle, can really nicely recover after the transplant procedure to an almost normal situation, as shown here on the right side. And also the survival outcomes have shown that a bilateral lung transplantation is associated with comparable outcomes compared to the initial heart-lung procedures performed. So this has become the standard of care for patients with PAH. Doing a single lung transplantation, which would be a technical possibility, is not recommended because due to the prevailing increased pulmonary vascular resistance in the non-transplanted lung, all the volume goes to the newly transplanted lung, leading to a volume overflow with initial hemodynamic instability and a higher rate of primary graft dysfunction, and in the long run leads to a ventilation perfusion mismatch between both sides. So this is not a recommended option. Really, to avoid this situation that the full cardiac output goes to a single transplanted lung, a bilateral procedure performed with the use of extracorporeal support intraoperatively is the standard procedure for PAH. From the technical perspective, the surgical access can be gained either by a clamshell incision or by two separate anterolateral thoracotomies, depending on the situation of the patient. Usually thoracotomies are feasible as well, and the cannulation is usually done in a central way in the aorta and in the right atrium. The surgical technique itself is pretty much standardized for lung transplantation and is in PAH patients comparable to any other transplant procedure, of course, with some particular issues regarding the management of the heart, but basically a bronchial, atrial, and an arterial anastomosis are performed, and this procedure is done bilaterally in a sequential way. The main issue in PAH are the peri and postoperative challenges associated with the disease. So we do know that the early postoperative period is tricky regarding the management, and this is the highest risk situation in IPAH patients. Whereas if this initial critical period is overcome, the long-term outcome for PAH patients are among the best that can be achieved with lung transplantation and really excellent. So the main issue in the postoperative phase is not anymore the right ventricle, because if the increased pulmonary resistance is gone, the right heart quickly recovers after lung transplantation. And here are some images which nicely demonstrate this. It's always pairs of the same patients, where on the left side, you can see the massively increased size of the heart prior to transplantation and the complete recovery to a normal cardiac size after the transplant procedure. And this is really observed in those patients typically after bilateral lung transplantation. The main issue, however, is the left ventricle, which gets a lot of volume through those lungs, which is not used to. And there are several strategies that need to be addressed to avoid this left ventricular decompensation. One important issue is a prolongation of the extracorporeal circulation support into the postoperative period. And we have shown that this routine prolongation into the postoperative period really leads to increased survival rates compared to if this postoperative prolongation is not used. And then there are several other management strategies like fluid restriction, early initiation of hemodialysis if required, which does not impair kidney function in the long run, but really leads to excellent outcomes regarding the weaning and the critical postoperative period. And adding all these management strategies in the perioperative setting has really been able to substantially improve the early and long-term survival rates of PAH patients, as shown in the survival curve of patients transplanted for this indication at the center in Vienna, and really excellent long-term survival rates and quality of life can be achieved. So in summary, with regard to the operative setting, double lung transplantation with intraoperative veno-arterial ECMO is associated with excellent outcomes. Acute left ventricular failure is the main challenge in the early postoperative phase, and how this excellent long-term outcome and quality of life translates into real life. I want to show you with a few slides. We had some expeditions organized by Peter Yaksha, our transplant pulmonologist, initially to Kilimanjaro and also to Jebel Tukkal, as shown here with patients after lung transplantation. And this really demonstrates how excellent quality of life can be achieved after the transplant procedure. And we're taking this one step further in January next year, and with a group of patients in an international European and North American collaboration, going to try to summit Mount Aconcagua. And this, of course, is only possible with really an excellent and dedicated team, which we do have here in Vienna. And with this, I want to thank you for your attention and look forward to questions.
Thank you very much, Professor Aigner. We have one question from Bruno. In light of emerging evidence on remission potential and pronounced RV reverse remodeling with sotatercept, to what extent might this translate into a reduced need for lung transplantation in PAH?
Well, of course, all the new medications, including sotatercept, really work excellent for subsets of PAH patients and are able to either reverse an existing right ventricular dysfunction or hypertrophy. However, they do not work in all the patients, and in some patients we really have a risk category from the beginning on, where sometimes, depending on how early the diagnosis is made or not, this reversal cannot be avoided in a safe way without having the safety nets in case of an acute decompensation of doing a transplant procedure. So I really think sticking to the referral criteria and a clear categorization in the established risk categories is an important issue, and establishing the possibility of a lung transplant early in the disease does not do any harm, and you always have the option as sort of a safety net in case a deterioration occurs. And if it's not required, we're very happy that we don't have the necessity for transplanting the patient.
Thank you very much. And thank you for that question, Bruno. So, yeah, it's time for our next presentation. And that's going to be between Jan Verstraete, Project Manager at the Patient Expert Center in Belgium, and Wendy Vansteenkiste, who is a PH patient advocate with the Belgian PH Association. And I'm just going to pull up the recording now. Yeah, Jan is here with us today. Thank you very much, Jan. And yeah, Wendy couldn't be here, so we recorded it. And I will pull up the recording now. Jan, anything you want to add while I'm getting the recording going?
No, thanks for the opportunity to be able to present this our project here, but no, I hope most of the information is in the video we made last week, and then I'm there to answer any questions if any.
Okay.
Hi everyone, I'm Wendy Vansteenkiste. I'm president of the Belgian Patient Organization and focused on the Dutch-speaking part of Belgium. And I'm a patient myself. I received my diagnosis in 2009. Today we will talk about the Pulmonary Hypertension Patient Information Project. This is a project we started last year together with the Patient Expert Center, here represented by my co-speaker Jan Verstraete, and HTAP Belgique, the French-speaking patient organization in Belgium, with his president Luc Matthijssen. But first, we would like to thank the Alliance for Pulmonary Hypertension for their invitation to talk about this project. So first, I will talk about the design of the project, and then Jan will talk more about the hurdles we encountered in the first phase of the project and the results of the first phase. And then I will give an insight into the next steps in the following phases of the project. The Pulmonary Hypertension Patient Information Project, PHPIP in short, wants to offer a systematic way to develop and maintain patient educational materials about pulmonary hypertension, and this as a collaboration between all stakeholders. Why? Because in practice we see that many initiatives related to the pre-competitive patient education on pulmonary hypertension are being launched by different stakeholders. However, these efforts often lack coordination and collaboration, which results in fragmented and inconsistent materials. And moreover, we saw that many of these initiatives appear briefly and then disappear, often before they even fully reach the patients. So this highlighted the need for a more unified, structured and sustainable way of making new materials. We also observed the significant differences in the type and the quality of education of patients. So this inconsistency reinforces the need of a national coordinated approach, ensuring that all patients, regardless of location or circumstances, have access to the same reliable and comprehensive information. PHPIP is guided by the Patient Expert Center, which plays a key role in shaping and supporting the initiative. Why PHPIP? Well, when we look at the benefits of this initiative, we see a clear added value for all stakeholders involved. So for the patient, it means that gaining more knowledge about their condition, experiencing fewer uncertainties, having access to a central source of reliable information. This empowers the patients and helps them to feel more supported throughout their care journey. For healthcare professionals, it results in fewer practical questions and more focused, meaningful inquiries for patients. And this allows for more efficient consultations and improved care outcomes, ultimately leading to higher satisfaction with the care provided. And additionally, it eliminates the need for duplicate efforts, such as proofreading educational materials. For the industry, it ensures that products are used in the best possible way by well-informed patients. It also presents a valuable opportunity for collaboration with all partners in the healthcare ecosystem, enabling shared efforts and mutual support. For hospitals, it removes the need to create their own materials on general topics, saving time and resources. And for us as a patient organization, it offers a chance to demonstrate our professional role we want to play and showcase our expertise in supporting patients. So as you see, we all have needs. The patients needs information, the healthcare professional needs materials to illustrate their message, and the industry wants the product to be used in the best possible way. We all have knowledge. The patient knows best what it is to live with the disease. The doctors know best how the disease can be treated from a medical point of view. And industry has a lot of knowledge to make, for example, materials as attractive as possible. And we all have resources. The patient organizations and the doctors have access to patients. Industry has the financial resources. And with this project, we want to bring this all together to achieve the best and most efficient result to create these educational materials. We are convinced that this is a unique pilot project that is not only addresses the specific needs of patients with pulmonary hypertension in Belgium, but we hope it can also serve as a model for other countries or therapeutic areas. By taking a centralized view of patient needs, the project enables a clear identification of existing gaps in the indication and support of patients. And one of the key strengths of the PHPIP project is the cost effectiveness, because by developing pre-competitive educational materials collaboratively, stakeholders can share costs while avoiding duplication. The materials are managed in-house, meaning that there are no royalties to pay, which was for us a very important topic. And the Patient Expert Center provides also a sort of a quality label made with patient experts. Looking ahead, we want to create this project and this design to be future-proof. The project is centrally managed by patient organizations, and it will be also made flexible, allowing for easy updates and adaptations. And while coordination is centralized managed, there will be room for local accent and customization, for example, practical details by hospital. So finally, we want to try PHPIP scalable with a structured approach that will make it possible to export this to, for example, other countries or therapeutic areas if there is interest too. The project is based on the expertise and the methodology of the Patient Expert Center, and based on their methodology, we will do the next steps. The first three we already did in phase 1. That was identify the information needs at each stage of the patient journey, but Jan will tell more about that. Gather all available resources and define the logical order in which the materials should be developed. Later on, we will create the content, distribute and implement the materials, and evaluate and refine the materials continuously based on the feedback for patients and professionals to keep them up to date and impactful.
Yeah, so thanks, Wendy, for explaining the design of the project, and I'll try to guide you all through the reality and the hurdles we encountered during the execution of the project. So one of the hurdles, let's say, or the reality checks we had was that it is quite a bit of work, or quite a bit more work than we expected, or at least some parts of the project. So first of all, it was a completely new concept. So we need quite some time to explain it to everyone, to all the stakeholders. I'll come back on that. And then also we needed to convince them to collaborate with their people's knowledge, mainly on the healthcare professionals, but also to get some financial support, because we spent quite some time and hours, and that costs a bit of money. And secondly, it's linked to the nature of hospitals, that actually it's hard to plan and to find people together to plan meetings together with several hospitals and several people. So we tried to meet, first of all, everyone together, but that didn't work. So we had to meet every hospital team separately, which actually was quite some more work, but in the end we got better result because we have one-to-one discussions, and the people are more engaged in the project. Everyone knows what it is about, and everybody has had his input. So probably, let's hope, the end result will be used more. Then a third point are the patient pathways, where we estimated that we would have enough detail with a draft patient pathway, but the project taught us that we need a quite detailed pathway. So it was quite a lot of work indeed. That's the patient journey part. You see, it's about 20% of the time went to there. And it's a lot of work, mainly on layouting. It's to make it readable, to keep it usable. And then the planning, that's what I already said. A lot of time went into planning and scheduling meetings with this big group of people, which is on the next slide. So we got all these people around the table, which is great for the collaboration, but again, it required some effort to plan meetings with everyone. Voilà. So as explained, we had a bit more work, and you can see we made a planning. We tried to plan this as good as possible. And there you see clearly that the patient pathway and the pitches to the healthcare professionals took extra time. This is similarly, it's here, it's more the budget instead of the hours on the previous slides. But here, so we got budget from sponsors, for which we are very grateful. But probably in the future, we will need some new way of structurally supporting this, since it is not a one-time project. The idea is to have a new system. It's a way of working, and so that actually the patient organization handles all the information for the patients. Let's say all the pre-competitive information, so everything that it's not specific to a treatment or to a hospital. So we will need to think about more structural support. If anyone here has ideas, please let us know. There was a small issue with VAT that's quite technical, but it means the patient expert center has VAT, so it's then we don't pay them, and then other patient organizations, they are not obliged to charge VAT, but then they pay VAT. That's a detail, but it made quite a difference. So honestly, luckily, we had some results, some good results. So as explained, we drafted a patient pathway. We needed it to be able to identify on the patient pathway which information is needed for the patient. It was more work than foreseen, much more work, but the result is actually quite infallible. We had several iterations, and we ended up 1, 2, 3. You see on the slide, we ended up with a metro mapping based style. Metro mapping is a Dutch methodology, or developed in the Netherlands. The idea is that it's a very useful way of visualizing a patient pathway. And we did not completely use the metro mapping, because we considered it too late, and we had already spent quite some work in making it in this shape. And also we don't have the Visio software on which it's based. Metro mapping in itself is open source. You can just download the tool, but you need the Visio tool of Microsoft to use it. It's a very good working document where you can clearly see all the steps and all the phases in the full disease, from early signs to end of treatment. And then on the lines below, you see the context and the contacts of a patient, also the information needs, and then we indicated in the 2 bottom rows, we indicated the existing information, and so the difference of both is the information that need to be created. Our idea is for the next phases is to review this and have this redesigned in a a bit more user-friendly way. But this is a very good working document. It's way too complex to use on a day-to-day basis, but to manage stuff or to see what a small change in treatment could mean in a pathway of a patient, that's actually a great tool. The second deliverable, the second result of this project was that we have collected a lot of information. We have collected about a little 100 documents, 80 and some on SharePoint and some physical documents as well. And we organized them. And if anybody has more information on pulmonary hypertension, we can gladly share the link to dump your information. I think we have information in Dutch and French and in English. So. And the third deliverable of the project is actually the priorities. It's a very good working document where you can clearly see all the steps and all the phases in the full disease, from early signs to end of treatment. And then on the lines below, you see the context and the contacts of a patient, also the information needs, and then we indicated in the two bottom rows. But during the workshops we had of the project and with all the stakeholders, we decided on the priorities, and the first priority that came out of this meeting is actually a base document that is given in the pre-diagnosis phase. So actually during the medical tests, and the document explains all forms of pulmonary hypertension, and also explains the tests to get to the correct diagnosis afterwards. So for example, an explanation of the right heart catheterization. And then the second priority is this patient roadmap, which is actually a simplified version of the full patient pathway we designed. And the idea is to publish it on the website, and that it's like the framework for all the next steps, and also that you can zoom in on, for example, on the website, that you can zoom in on a specific part of the roadmap, and then you get more details on that phase in the disease. And then the start kit is only priority 3 now, and then we'll go further down but then we are talking in 1 or 2 years. So what did this total project so far cost? We got funding for about 22,000 euros for the first 3 steps, and we spent a bit more. 27,000 euros we spent, and it was all on work. Actually, the most of the work is really on the cost. I mean, is on hours, is on man hours, as we say in Dutch, but it's effort spent by us, by the team. That had really little external costs so far.
So to end, I will give you some insights in the next steps for the coming phase. So looking again at the project design, the next steps are clearly identified. So if we look a little bit more in detail for this base document, this will explain the diagnostic examinations that are typically performed when PH is suspected, along with the possible outcomes of these tests. So this is a document that will be given at the patients at the moment when there is a suspicion of pulmonary hypertension. So the doctor can explain what to expect, which examination that will be performed, and which are the possible outcomes. So for that, it will cover all forms of pulmonary hypertension, including the more common non-rare types, because at this point, when PH is suspected, you don't know yet what to expect. The content will be based on the image of the 22 clinical guidelines, and will take inspiration for the great example already created by the Dutch colleagues of Stichting PH Nederland. Information will be organized in separate files or subjects, because we want to allow to make it tailored to the specific needs of the patient. So not every patient needs the same examinations, so you can literally take those information or educational materials that you need for that patient. You will also pay special attention to the differences in health literacy, making sure that the materials are suitable for various audiences, whether these are children, adults, or individuals with varying levels of medical understanding. So the patient roadmap, the simplified version of the patient pathway, will be specifically designed to be patient-oriented and really easy to understand. So this document will be given at point of diagnosis so that the patient will have an understanding of what comes next. At this moment, we see sometimes as patient when you have your diagnosis that you don't know what to expect, what are the possibilities, when can you expect a prognosis, how your treatment will evaluate. And so this is what we want to give here to the patients, that they know, okay, we were going to go in this direction. Then we have consultation 1, consultation 2. So this document will be given at point of diagnosis so that the patient will have an understanding of what comes next. For example, stable, and we have the integration into the daily life. So then we have the information that is needed when you want to go working or have hobbies. Then again, you have the disease progression. At that moment, you need other information. And at the end, you have the end of life care. So this will be like a guideline of what can be happen. This section will focus on the rare forms of PH in the first phases, such as PAH, CTEPH, and the pediatric PAH. And to ensure the accessibility and the flexibility, we will offer 2 versions of the roadmap. So one, a digital interactive version of it on a website, the central managed website, but also analog paper-based version that can be handed out during consultations. And we hope that this roadmap will be a valuable tool to support patients throughout their journey, helping to feel them informed, prepared, and empowered. So here you have some examples of a possible outcome. We don't know yet, but we collected some nice examples. This section will focus on the rare forms of PH in the first phases, such as PAH, CTEPH, and the pediatric PAH. And to ensure the accessibility and the flexibility. And that brings us to the end of the presentation. So we hope this overview has given you a clear understanding of the goals, the structure, and the potential impact of our project and what we want to do. Thank you very much for listening. And now we'd love to hear from you. So if you have any questions, I myself, I'm not there at this moment, but Jan will be there and Luc is there, so they can, if you have questions, you can ask to them. Thank you very much.
Okay, thank you very much, Jan and Wendy. Yeah, I think we're running a bit short on time for questions now. So Bruno is here in the meeting, and please send him any questions or any documents you may have via chat. And with that, I think we'll move to our next presentation from Professor David Montani, who is going to talk about the association between genetic data and response to sotatercept in the PULSAR study.
Yes, thank you. My webcam is off.
Oh, sorry, there now it should be on. Thank you. Sorry about that.
That's perfect. Thank you so much. So I will try to share my screen.
Perfect.
Is it okay for you? Yes, exactly. So thank you so much. So we will try to discuss genetic background and response to sotatercept. These are my conflict of interest. So very, very shortly, very briefly, we have a lot of genes that have been involved in heritable PH, where all these genes are considered to be associated with pulmonary arterial hypertension. And the most frequent mutation observed in heritable PH is BMPR2 mutation, the first gene that has been discovered in the field of PH. What is exactly BMPR2? BMPR2 is a protein, a receptor, that play a role of brake for proliferation of cells in the pulmonary vascular bed. So when BMPR2 work, it play a role of brake and avoid proliferation of cells of pulmonary arteries. But when you have a mutation of BMPR2, you have no brake, and there is an increase of the proliferation of cells that progressively induce pulmonary arterial remodeling and PAH. What we know about BMPR2 mutation carriers is that patients PH patients who carry BMPR2 mutation had a severe form of PH, more progressive form of PH, and usually they are younger and with more severe hemodynamics at diagnosis. One point that is very important is that, in fact, of course, when you have a mutation in BMPR2, this pathway is abnormal because you have the mutation, and so the expression of BMPR2 is very low. But it was also the case for patients who have other form of PH or idiopathic PH without mutation. That means that BMPR2 pathway is abnormal, not only in patients who carry the BMPR2 mutation, but also in all forms of PH. That may clearly potential target to treat PH, because we know that BMPR2 is abnormal in all PH patients. During several years, we tried to correct BMPR2 expression by different pathway, but no treatment achieved to restore BMPR2 pathway in PH. And more recently, we discovered that BMPR2 is not an only pathway, but it's a balance between BMPR2 pathway that play a role of brake, anti-proliferation, and activin pathway who play the role of proliferative effect. And in healthy subject, it's a balance between this anti-proliferation and proliferation in healthy subjects. But in PH, we know that there is a decrease of BMPR2 expression, decrease of the BMPR2 pathway, but also we discovered that there is an increase in activin pathway. So there is clearly an imbalance in favor of proliferation of cells. We are not able to target directly BMPR2, but with sotatercept, we are able to target the ligands of the activin pathway. That means that we are not able to increase the BMPR2 expression, but we are able to decrease the activin pro-proliferative pathway and restore the balance. And so we restore the normal proliferation of cells in pulmonary arteries. So there is a question about patients who have BMPR2 mutation. Should this patient respond better than the other or not? It was an open question. So in this study that I will present to you, we will look at what is the response to treatment to sotatercept in patients with BMPR2 mutation and in patients without BMPR2 mutation. It was published this year in American Journal of Respiratory and Critical Care Medicine. And it was data from PULSAR study. PULSAR study was a phase 2 study, a double-blind, placebo-controlled clinical trial that evaluates the effect of sotatercept versus placebo in patients with PH. And in this study, we decided to look at the genetic background and to look if it changed the response to treatment. To do this study, we exclude patients with connective tissue disease because it's a different response to treatment. And we know that there is no genetic background in these patients. So we compare patients with idiopathic or heritable or familial PH. We have no pathogenic variants, no genetic background. And we look at patients who carried genetic variant, and it was BMPR2 for 23 of these patients. And we compare the response to treatment, but also the safety of treatment. What we saw, but it was known that BMPR2 patients were younger at diagnosis, at the severe pH, and they are more prone to have triple therapy, and they had a lower NT-proBNP, probably because they had more aggressive treatment and they are younger than the others. And if we look on the answer to sotatercept, the efficacy of sotatercept in this patient, there is no difference regarding the genetic background. If you have a BMPR2 mutation or no BMPR2 mutation, the good news is that you can respond to treatment by the same way, with a decrease in PVR, an increase of 6-minute walk distance. The only difference is for NT-proBNP, a biomarker of right heart failure, because there is a lower decrease in patients carrying a BMPR2 because they are a lower level at baseline, so they cannot decrease. But if we look at the final NT-proBNP, is totally similar in the two groups. That means that the patient reach a low risk of level of NT-proBNP in BMPR2 patient and patients who do not carry BMPR2 mutation. There is a question about the safety of sotatercept because there are some adverse events, and particularly hemorrhagic complication. And there is no difference between patients carrying BMPR2 or who have no, and patients who have no mutation. The same proportion of serious adverse events. That means that it's safe, whatever is the genetic background of the patient. Another information for this study is that we identified 2 patients who have a specific pathogenic variant, not BMPR2, but other pathogenic variants. And of course, we cannot have definite conclusion based on only one case, but it can give some information for clinicians. We have a patient with ACVR1 mutation and a patient with BL allelic EF2AK4 mutation. ACVR1 is very interesting because it's a gene, predisposing gene of PH, but also of hereditary hemorrhagic telangiectasia, HHT, Randu-Osler disease. And we know that patients with carrying ACVR1 may be at risk of hemorrhagic complication, and we do not know if they can respond to sotatercept. It's only one patient, but what we can see is that this patient with ACVR1 mutation had a good response to treatment, a decrease of PVR, about 2 Watts unit, an increase of more than 100 meters on sotatercept, and a huge decrease of NT-proBNP on treatment, and there is no serious adverse events during the study. So it may bring some information, but it's only one patient. The second patient had BL allelic EF2AK4 mutation. This mutation predisposed to a very specific form of pulmonary arterial hypertension that is called pulmonary veno-occlusive disease. And in this disease, to date, we have no proof that the current treatment we use in PH were useful and safe. And so usually these patients require lung transplantation, and they do not respond to treat vasodilators to date. And interestingly, there is one patient in the study with heritable pulmonary veno-occlusive disease, and you can see the answer to treatment. We also observe a significant improvement in PVR to reach PVR of 2, an improvement of 6-minute walk distance, and the patient keep a very low NT-proBNP and no serious adverse events. So also it brings some information for this rare form of PH in which we have no treatment, but sotatercept may have an effect also in this form of PH. And finally, in conclusion, we saw that patients who carried BMPR2 were younger and are more prone to be on triple therapy, higher 6-minute walk distance and lower NT-proBNP at baseline. But the treatment effect of sotatercept on resistance and 6-minute walk distance was consistent across patients with BMPR2 mutation and patients without BMPR2 mutation. The adverse profiles was also similar in the 2 groups, and we have some information about rare genetic variants. But of course, we need more data in the future in patients treated with sotatercept. But it's very interesting study because it was the first study where we have the genetic background and look at what is the response to treatment. And I think for the next study in future, probably genetic testing may be done for this patient to see if one day we are able to have a personalized medicine, to choose the good drugs for the good patients and not to treat all PH patients by the same way. Thank you very much.
Thank you very much. Do we have any questions right now? Bruno has a question. About 10% of patients show a super response to sotatercept. Which factors are associated with this pronounced benefit? Are there any genetic hints?
We have not the answer to date. Probably we should collect all these super responders. I'm not sure what is really a super responders because, of course, sotatercept is added on top of patients who have triple therapy or dual therapy. So we do not know if these patients will have the same response if they had not the other treatment. So it's probably the combination that leads to a super response. But of course, I think we should collect data from this patient, and I'm quite sure that we should better phenotype the good responder for all drugs, in fact, and for the future drugs to try to define what is a good patient for the good drugs and to go to personalized medicine. But to date, in PH, it doesn't exist. If we go in another field, for example, asthma, we decided the drugs according to some blood samples, biomarkers. But to date, we are not at this stage in PH, but I think it's the way we should go in the next years.
Great, thanks. And then we have one very specific question, and just say if you don't think you can answer it. Can sotatercept be affected for PVOD PH? It's also called veno-occlusive.
So the question is, yes. We know that in pulmonary veno-occlusive disease, of course, we have some specific mutation, but if we look at the expression of BMPR2 in this patient, is also abnormal. So I think we have quite no data about activin, but we can imagine that the imbalance between BMPR2 pathway and activin pathway is maybe also abnormal in pulmonary veno-occlusive disease. So I think we should work to confirm this data. And if it was the case, we can imagine that sotatercept may be a new drugs for this orphan disease. And you know that vasodilators such as ERA, PDE5 inhibitors of prostacyclin can induce pulmonary edema in these patients, but it was not the case for a treatment that could target directly pulmonary vascular remodeling. So it opened an area of research, but we cannot conclude based on only one case, of course.
Mm-hmm. Yeah. Great. Thank you so much, Professor Montani, who is a professor of respiratory medicine at the PH Referral Center at the Hôpital Bicêtre in France, and now one of Professor Montani's colleagues from the same center, Olivier Sitbon. Professor Olivier Sitbon is going to share with us. Olivier?
Yeah, thank you. Thank you for your kind introduction. The name is Bicêtre.
Bicêtre, thank you.
So now, thank you very much again for your kind invitation and the invitation by Pisana. It's a great pleasure to present the use of PROMs in routine clinical practice. So I'm going to share my slides now. I think it's here. Does it work?
Yes, it works. We see the presenter view.
You see the presenter. Sorry. Let me change.
There we
Yeah,
go. Perfect.
That's it. It's fine.
Yes.
All right. So I'm gonna discuss the use of PROMs, patient-related outcome measures, in routine clinical practice, and now we have an experience in not only in Paris Center but in the whole PH network in France. So that's my disclosures. So just to start with this cartoon about summarizing what is the treatment goal. What is the treatment goal for a doctor? For a doctor, the treatment goals are as follows: improve survival, reduce hospitalization, improve RV function, improve exercise capacity. And finally, as you can see, the improved quality of life is on the bottom. Of course, if you what is relevant to patients is, of course, very, very different. And for the patients, improved quality of life is on the top of these expectations. Improve daily life activities, tolerate medication and minimize side effects, avoid hospitalization. And finally, the majority of the patients, they don't care about the RV function. What is important for them and for you are to improve the quality of life. And as you know, at the last World Symposium in Barcelona last year, we put the patient's perspective as the task force #1. And Pisana and Giorgeli and some others participated to this very, very important task force at the last World Symposium. You know that PAH is as severe as other serious debilitating condition, and the impact on health-related quality of life is very, very important. As you can see here, this is the scores from the SF-36, physical component and mental health component. As you can see, PAH here in gray is as severe as we can see in COPD, ILD, cancers, and other debilitating conditions. And also, we know that a significant proportion of patients with PAH or with PH in general experience mental disorders. And if you look at any mental health disorder, 1/3 of the patients experience this kind of disorders because there is a big impact of the disease on the mental health. And we also know that the patients with PAH suffer from depression, anxiety, and stress. And we can observe this at any stage of severity of the disease, mild, moderate, severe, or extremely severe symptoms. As you can see, those patients, some of them, they have depression, anxiety, which is much more common, and stress. So that's why it is very important to assess quality of life, which is, we know that it's very broad, complex, and subjective. And we know that it is very, very individual. And the perceptions are very, very individual regarding the health risk and condition, functional status, social support, socioeconomic status. So we can assess this from how are you doing today, which is the simplest way. Functional class is very, very commonly used to assess the kind of quality of life, but we also go to the real health-related quality of life and PROM, patient-reported outcomes measures. Let's start with functional class. We know that functional class is very, very difficult to assess. What we call sometimes WHO functional class, which does not exist. It is NYHA functional class. I just want to say functional class. So we know that to consider functional class 1, 2, 3, or 4, the many physicians, they do not consider just the assessments of functional class. They consider other variables to assess functional class. They consider hemodynamic values, they consider physical examination, 6-minute walk. If you have a patient walking 200 meters and claim that is in functional class 1 is probably not true. So many physicians, they consider other findings of other metrics to assess functional class. And this is an interesting paper. It is published, it has been published 15 years ago, about some 10 patient case scenarios analyzed by PH experienced physicians and nurses. And as you can see, in both physicians and in nurses, in some scenarios, we have physicians, for example, for this patient number 6, for the same scenario, 2 physicians considered that the patient was functional class 1, some other functional class 2, functional class 3, or functional class 4. So it is very complicated to define functional class, and there are significant variation in the clinical case assessment of functional class. That's why PROMs have been introduced to assess the not only symptoms but also quality of life and some impact of the disease on psychological impact, physical impact, social impact, and that's what PROM are made for. And we also can use PROM in interventional clinical trials or as quality indicators, but today we have to concentrate on the use of PROM in routine clinical care. We know that PROMs have been used in routine clinical care and research for PAH, and this is a list of some PROMs. You have the non-specific PROMs like the SF36 or the EQ5D, and we have a list of PH-specific like COMFOR, Vansteenkiste, living with PH impact which have been developed especially for pulmonary hypertension. All those questionnaires of PROMs, they correlate with very important metrics like walk test, functional class, BNP, sometimes hemodynamic survival as well. So I think there are good correlation with very important metrics, and we also have different methods to assess those questionnaires. Like, for example, for Vansteenkiste is a 6-point semantic differential methods. For living with PH, that's a 6-point Likert scale. So and the time to complete to fill the questionnaire is very variable from a questionnaire to another. Let's start with the SF36 questionnaire, which is non-specific. We have some component, a physical component score, and some mental component score, including mental health or emotional, social functional vitality, etc. We know that the pH management, this is an example in the Seraphim trial with macitentan, that when we give the drug, it's better than placebo in terms of improvement of the component of the SF36 scores. As you can see here, in red, that's the treatment, it's better, and in gray, that is the placebo, which is worse. So we know that with the treatment, we can improve the component of the SF36, and this is also correlated with the outcomes. This is not the survival, this is the time to first confirm morbidity or morbidity event. And according to the median baseline SF36 component, either physical or mental component, this is highly associated with outcomes. And let's move to another PROM, which is the pH SYMPACT. The SYMPACT is a specific patient-related outcome tool developed in accordance with the FDA PRO guidance. It evaluates 11 pH symptoms and 11 impact items. This includes cardiopulmonary symptoms, also cardiovascular symptoms, and in terms of pH impacts, not symptoms, but impacts, it assesses physical impacts and cognitive and or emotional impacts. I don't want to go into too much detail. it works. And if you look at the different domain, cardiopulmonary, cardiovascular, physical impact, cognitive or emotional impact, there is a very good correlation with functional class, for example. So when you have the patient in functional class 2, it's better than to have functional class 3 and functional class 4. It's obvious for cardiovascular symptoms or cardiopulmonary or cardiovascular symptoms, but also it correlates with physical impacts or cognitive impacts. It is also interesting because it changes over time, and when you have patients who decline or who stabilize or who improved, as you can see, we have different evolution of these different symptoms or impacts. Let's move now to emphasis 10. Emphasis 10, that it is what we use now we are using now in the French registry. Emphasis 10 have been developed in the United Kingdom, and it measures the impact of pulmonary hypertension of quality of life. It has been developed from interviews conducted with 30 PH patients, and as I mentioned previously, that a semantic differential 6-point scale from 0, 1, 2, 3, 4, or 5. And we have 10 questions, six kind of response, and the patients, it is a self-administered questionnaire, and the patients is doing this, for example, during the outpatient consultation. It is very, very sensitive to difference in the relevant clinical parameters. It is freely available, and it has been translated in 25 languages. In France, that we are using, here we have the French translation of the emphasis 10, and it has been used now. It is used now in the French PH network since January 2024, less than 2 years. Now we have been able to collect more than 2,280 emphasis 10 score recorded in almost 1,500 patients, including 230 incident or newly diagnosed patients and 1,200 prevalent patients. More than 461 patients had filled 2 or more questionnaire, including 8 or almost 100 with baseline assessment, baseline, first follow-up, second follow-up, etc. So it is very important to follow regularly those patients, also with the quality of life questionnaires. This is the patient demographics, majority of female, 58, and 42% male. The mean age was 62. We have a majority of patients with PAH, but also a significant proportion of patients with group 3 or group 4, CTEPH. We have 230 incident case. And if you look at the outcome now, we have 44 patients that died and 11 underwent lung transplantation within the 2 years follow-up. This is the patient characteristic according to all the emphasis tests that have been filled. So we have a majority of patients in functional class 1 or 2 because that majority of prevalent case that patient already treated. The 6-minute walk is broadly 400 meters. Here you have the median for the BNP or NT-proBNP. This is within the normal range, but just for the median. And here we have the hemodynamics of the patients. Also, the hemodynamics is not that severe because we are looking of the emphasis 10 score in patients in prevalent cases. If you look at the correlation, we found a very weak correlation with pulmonary hemodynamics and NT-proBNP, which are very, very important, metrics in PH. But we have a quite nice correlation with functional class, 1, 2, 3, and 4. This is a score of emphasis 10. But as you can see, you have also a huge distribution. And for example, in functional class 1 patients are very good. The majority, they have a low score, less than 10 or 20, but some of them, they also have a high emphasis 10 score. If you look at the correlation with the 6-minute walk distance, there is a correlation, but as you can see, the distribution is very big, and you have a huge variation for the same level of emphasis 10 or the same level of walk test. For example, 400 meters, you have patients with a score of 0, and some of them, they have score of 50. So I think we have there is a correlation, but the distribution is very, very broad. This has been already shown in the UK registry. There is a good correlation with the functional class again here in these two papers published from the UK registry. In the French registry, we look also at the correlation with the risk. You know that you can assess the risk with some metrics like functional class, walk test, and BNP or NT-proBNP. And according to the risk, the higher the risk, the higher the emphasis 10 score. But that's only mean and standard deviation. And if you look this on the right-hand side here, you have huge variation in the emphasis 10 score according to the risk, and you have patients at low risk with a low emphasis 10 score and some other with a high emphasis 10 score, and vice versa. So yesterday I saw 2 patients, young patients. One was with almost normal hemodynamics on therapy, and the emphasis 10 was 40, sorry, which is very, very elevated. And in contrary, on the opposite, I have another patient with very low emphasis 10, 13, which is very, very low, and a very, very severe hemodynamic. So it's difficult to have a perfect match between the clinical status, the hemodynamics, and the emphasis 10 score, because probably emphasis 10 score or PROM say something different than the classical metrics we are using to assess for example, the effect of therapy in patients with PAH. And this is also the data from the UK registry showing that there is a good correlation between the emphasis 10 score and the outcome. But this is, we did not have the same analysis in France, but we will do it soon. So this is my last slide about the clinical use of PROM in pulmonary hypertension. This is a slide, a picture I took from a recent paper published in the Journal of American College of Cardiology. And as you can see, what is interesting for us, that patient care, the clinical use of PROM. This is a development of PROM, and this is when you are using PROMs in patient care to assess clinical status for prognostication, to assess treatment response, perhaps, to also to look at the patient-physician communication, which is also very important. And here you have the pro and con of the 3 PH-specific PROM. For example, emphasis 10 has excellent feasibility for clinical use because it's very concise format and easy interpretability. PH impact has been developed according to FDA standards for clinical trials, but there is limited data on interpretability and feasibility in clinical practice. And COMFOR was the first developed PRO, but is very long. There is very, very long completion of time. Otherwise, COMFOR is also, we have to pay to use it, which is also an issue. So the majority now of people, they consider using emphasis 10, because emphasis 10 is very, very simple, and that has been also developed within the ear and lung. And within the ear and lung, the PROMs are very, very important to consider, and that's why we decided to use emphasis 10, not only in the French registry, but also in other centers participating in the European Rare Network dedicated to the lung, and in particular in the PH core network. So thank you very much for your attention.
Thank you very much, Professor Sitbon. That was excellent presentation. We had one question, or a few questions actually, to ask you. Do you use the results of the PROMs in your consultations? Meaning, do you discuss the results with the patient that you're seeing and use it to get to know kind of what their real struggles or daily challenges are? And do you use it in treatment decisions?
Yes, very important question. So we use regularly the results of the emphasis 10 in the consultation. We have to learn more about the emphasis 10 score, because as I mentioned, we have patient, we have very, very good outcome, very, very good results with the treatment. And sometimes we have very high level of emphasis 10, very high score. High score means there is something wrong. So, and we have to, this help us to look at what is wrong, because for us, our expectations are good. Good walk test, good BNP, good hemodynamics. We are very happy with this, but the patient is not happy because the emphasis 10 score is very, very elevated. So we have, this is helping us to better understand what is wrong, what is the problem. For example, the problem could be side effects, for example. If you have side effects, too much side effects because of sub-Q prostacyclin, sub-Q prostacyclin induce sometimes very severe pain. And it is an effective treatment, but it induces pain. So, and this is reflected within the PROM. I think it is important to consider. And we will learn every day much more about how to integrate those results in the care of patients.
So far, what is the reaction of patients when you're introducing PROMs in the routine care? Do most appreciate it? Do some see taking some of the PROMs as burdensome? What's your experience?
Sorry, can you rephrase the question?
Yes. How did you present the introduction of PROMs in routine care to your patients, and what was their reaction?
No, I think when we discuss with our patient, we just tell them that it is important to have a more precise evaluation of their symptoms and the consequence of the disease on their daily life activities, for example. And they are very, very happy to feel it. Sometimes some questions are more difficult to understand, and it is a self-administered questionnaire, but sometimes we have to explain more in detail what does it mean. For example, there is a question about the burden of the disease, and sometimes it's not that easy to understand for some patients, and we have to explain, but it is we can explain as a doctor, or the nurse can explain, and now they are very, very happy to feel at each visit, at each hospitalization, each visit, outpatient consultation, they feel the emphasis 10. So now the people who are doing the 6-minute walk test, they do on the same time the emphasis 10 questionnaire. So for each patient with a 6-minute walk test, we have an emphasis 10.
Great, thank you. Luis says thanks for the nice answers, very helpful. Pisana has a follow-up question. PROMs also have a role in empowering patients. They encourage them to focus on their own experiences and feelings and encourage active self-monitoring and paying close attention to symptoms, side effects, and warning signs. Would you agree?
I strongly, strongly agree with you, Pisana. I think it's very important to focus more on symptoms because symptoms are key. That's more important. And also the side effect, as I mentioned, for example, with subcutaneous treprostinil, but also with others, with other drugs. I think it's very, very, very important. We treat patients, we treat humans. We do not treat patients are not how to say that each patient is an individual, and we cannot have for the same level of severity. You take two patients and you have totally different response to the PROM. I think it's very, very, very important to continue to collect information, and it's a good start in the French registry, more than 2,000 questionnaires. I think that is very important. And Simon Gibb is proposing that PROMs are used at diagnosis. I agree.
Very
And it's
interesting.
very important to follow up with the regular monitoring of the PROMs.
Yeah, and Der from PH Turkey says thank you very much, very useful. And Elena says thank you very much. She was actually a patient of Professor Aigner in Vienna, and is grateful to him and his team. I think at least one or two others on the webinar today were also former patients of his. So yeah, thank you to him and to you, Professor Sitbon, and to all of our speakers today for sharing your time and your expertise with us. We so appreciate it. And yeah, I know this is the second webinar we've done together, at least second webinar we've done together. So we look forward to keeping in contact and yeah, continuing these kinds of conversations in the future. So yeah, thank you to all of our speakers. The full video recording will be up later today or tonight on the knowledge sharing platform and on the Alliance for Pulmonary Hypertension's YouTube channel. And then the individual talks as well as the slides will be available later this week in a few days on the knowledge sharing platform. So look forward to sharing that with everyone. And yeah, thanks again for tuning in and sticking with us till the end here. We had a great audience with great questions. And yeah, wishing everyone a good evening or a good rest of their day wherever they are.
Thank you.
Merci beaucoup.